Greetings and a warm welcome to all the dignitaries present here. I'm Rimpa from Clernet, serving as the allocator session assistant to ensure a seamless experience. Clernet proudly stands as India's most relied upon digital platform, offering a multitude of enriching services exclusively for the doctors. It is with great pride that Clernet serves as a digital partner for this event, and the focus of today's session is cardiac patient for non-cardiac surgery. Now, I would like to invite Dr. L. Meenakshi Sundaram, sir, a distinguished anesthesiologist and a academic leader. Sir has served as Dean and DME at several government medical colleges, including Theni and Stanley Medical College, Chennai. He is a former National Vice President of the Indian Society of Anesthesiologists and has held key positions including Governing Council Member President and State Secretary of ISA Tamil Nadu State Branch. Now, over to you, sir. Thank you.
Uh, Thank you very much. At the outset, I request our President, Dr. Munian, to offer his presidential address.
Good evening all. I am Dr. K. Munian, President ISA Pthukkottai City Branch. On behalf of ISA Pthukkottai City Branch, I welcome the moderator, Dr. Kumar sir, and the faculties from Meenakshi Hospitals and Meenakshi Mission Hospital, Thanjavur and Madurai, and our academic chairman, respected Dr. L. Meenakshi Sundaram sir, and the delegates for the academic programs. Today we are conducting 28th episode of second edition of ISA Pthukkottai City Branch in the name of Pthukkottai Bhudhan. Today we are going to conduct an online webinar in the name of cardiac patients for non-cardiac surgery. Cardiac cardiac disease may be either valvular heart disease or congenital heart disease, or in age-reduced it may be coronary heart disease. Managing cardiac patients undergoing non-cardiac surgery requires skillful considerations and their cardiac risk factors and optimization of their medical conditions. Perioperative evaluation, there are so many evaluation methods are available. One is a cardiac risk assessment. There are two cardiac risk assessments are available. One is cardiac revised cardiac risk index and the American Heart Association risk index are used to assess the patient's cardiac risk for non-cardiac surgery. Then medical optimizations, optimization of the patient's medical conditions, including hypertension, cardiac failure, and arrhythmias. And medical managements, careful management of the patient, such as beta blockers, antiplatelets, and anticoagulants. Perioperative evaluation managements, anesthetic technique. We can use either GA or general anesthesia or regional anesthesia according to the patient's surgical requirements and the patient's clinical conditions. Hemodynamic monitoring, closely monitoring the patient's hemodynamic status, including blood pressure, heart rate, and cardiac outputs. After cardiac, we are anticipating the cardiac complications like myocardial infarctions, heart failure, arrhythmias during perioperative periods. And the postoperative care, close monitoring the patient's cardiac status like the heart rate, blood pressures, and any associated arrhythmias. And also we got to properly give the pain management to avoid the cardiac risk index, overloading the cardiac stress. Multidisciplinary care, collaborating the patients with the multidisciplinary team, including cardiologist and anesthesiologist and surgeons. Key considerations. What are the key considerations in patients in postoperative periods? Individualized care, tailoring the patient's care to their specific cardiac conditions and surgical requirements. Communications, ensuring effective communication between the patient's healthcare team, including cardiologists and anesthesiologists and surgeons. And risk-benefit analysis, carefully weighing the risk and benefits of surgery and anesthesia in cardiac patients. By following these principles, healthcare providers like us can optimize the care of the patients undergoing non-cardiac surgery and minimize the risk of cardiac complications. Our speakers are interested to share their experience with all of us. Today, let's listen to the online webinar. Once again, I am asking our academic chairman and my respected professors, Dr. L. Meenakshi Sundaram is going to conduct ISA nationally president-elect. Kindly elect and select our academic chairman for the year 2025. Thank you, sir. Over to you, sir.
Thank you. Now I request our secretary, Dr. Kannan to offer his secretary report.
Good evening all. I am Dr. Kannan, Secretary, ISA Pthukkottai City Branch. Successfully, we are conducting 28th webinar of second edition of Pthukkottai Bhudhan today. Today, our topic is cardiac patients for non-cardiac surgeries. Our president has elaborated shortly about the topic. Last week, 23rd July, we have conducted 27th webinar of second edition of Pthukkottai Bhudhan. The last week topic was ultrasound guided regional anesthesia abdominal wall box. We have divided the topic into three subtopics. First subtopic, abdominal innervation. Second subtopic, anterior blocks. Third subtopic, posterolateral blocks. Our moderator was Dr. Lenin Babu, Professor and HOD, Jipmar Pulcheri. First subtopic, abdominal innervation was done by Dr. Emeline Rennie, postgraduate, Mahatma Gandhi Medical College and Research Institute, Puducherry. Second subtopic, anterior blocks was done by Dr. Nandini P., Assistant Professor, Mahatma Gandhi Medical College and Research Institute, Puducherry. Third subtopic, posterolateral blocks was done by Dr. Sweta, Associate Professor, Chettinadu Medical College and Research Institute, Chennai. Last week, around 778 delegates have attended our webinar. I wish our academic chairman, Dr. Meenakshi Sundaram sir, to win the president-elect 2025. Kindly support him. He is a good administrator and a good academic chairman. Kindly elect him. All our friends, kindly support our academic chairman, Dr. Meenakshi Sundaram sir, to elect president, elect president in 2025 ISA National. Thank you, Dr. Meenakshi Sundaram sir.
Thank you, Dr. Kannan. Now it is my duty to introduce the faculty to the delegates. We are extremely delighted that we have crossed the 50th mark and we are reaching that 28th. Our schedule is to have 52 webinars till the next January. So in spite of election fever, today the propaganda ended by 5 p.m. So 6 p.m. I have come for this Pthukkottai Bhudhan because it is a brainchild of ISA Pthukkottai, because this is a second edition. First edition we have conducted 52, and as a secretary pointed out, the last attendance was 778. Even 721 number seemed to be less, and the secretary used to call me, sir, it is only 721. So when all academic webinars are finding it difficult to reach the 3-digit, 721 seems to be the lowest number for us because our aim is 1500. So I request the delegates to please participate in the Pthukkottai Bhudhan, and our YouTube recordings are available. They can scan the QR code of mine. Then YouTube recording is seen by many people. That I have to say. So today in this cardiac patient coming for non-cardiac surgery, actually Dr. Muralidhar Kanchi from Narayana Hridalaya, Bangalore, he was a moderator for our previous cardiac session. He even messaged me that I would love to join this webinar. So he wanted the faculty link to join. So I have sent that. I have mentioned this is the greatest honor we can ever have. What I want to convey, this Meenakshi Hospital, Madurai and Tanjavur, invited even Dr. Muralidhar Kanchi from Bangalore to be part of the team. So the faculty and their technical expertise is so high that it has invited the top slot, Dr. Muralidhar Kanchi, to offer his interest to join the program. So today, the youngest faculty we used to say, the postgraduate will be the youngest faculty, but I don't know whether this postgraduate is the youngest faculty or not. But this postgraduate, Dr. Siva Prasath, why I am saying like this, he has done his MBBS in the year 96 to 2002. And he has joined Madurai Medical College in 2004 to 2007 and did his MD Anesthesiology. So once he has completed MD Anesthesiology, he joined Madurai Medical College as assistant professor. So you may be wondering, how come this MD qualified man suddenly become a PG? So in spite of all this, he is working in Madurai Medical College since the year 2008. So he is such a senior person. So he is even in Madurai Medical College, he is known as a great academician. If you want any person from Madurai Medical College to offer a lecture, they will mention only Siva Prasath. Many times I have asked, one and only Siva Prasath, I don't know, in Madurai Medical College, he got a very good name like that. And just as a hungry man for academics, he has joined Meenakshi Hospital as a DPNB postgraduate. Usually, the DPNB postgraduate is mentioned for a regular PG degree. And once, if you complete PG degree and join as a super specialty, it is called DRNB, so Doctorate of National Board. So I am seeing the first man writing as Doctorate of National Board is Dr. Siva Prasad. So he is interested in regional anesthesia and cardiac anesthesia. So naturally, he is going to deliver a lecture in regional anesthesia in cardiac surgeries. And his extracurricular activities are gardening. And super thing is, he is interested in veterinary anesthesia. So he may be anesthetizing even monkeys and elephants. Occasionally, I think he will anesthetize a human being. So this another faculty is Chennakesavalu from Tanjavur Meenakshi Hospital. He had wide variety of experience because he has done his MBBS from Karnataka. So he was registered in Karnataka Medical Council, MD also in Karnataka Medical Council, and DM is also registered in Karnataka Medical Council. But see, he has done his degree in all prestigious institutions like PGI Chandigarh, and Chitra Tirunal Institute. So Sri Chitra Institute, he has done his DM, cardiothoracic and vascular anesthesia. So I think he has the phenomenal capacity, and I don't know how many languages he know, because he knows all the languages. Because any person graduated from Bangalore, they will be minimum knowing 5 languages. So he knows Tamil, Telugu, Kannada, English, Hindi, Malayalam, everything, and he looks like a cine actor. And even though he is in Tanjavur, he is doing a good work, because Tanjavur usually reaching that top slot is very difficult in Tanjavur. But Chennakesavalu has achieved that, and he has so many publications to his credit, both national and international. Necessarily, he is interested in TEE and IACTA, Indian Association of Cardiothoracic and Vascular Anesthesiologists. So he is taking a key position in those anesthesia part. And even I'm also a member in that, but I joined as a member, then I forget about it. But these people are continuously involved in that. So I wish him all the very best. And it will be followed by Dr. Indu Kundandaiyan. So if you talk about Indu, you have to talk about Kundandaiyan also, the second half. So we used to say, in Tamil, there is a proverb, Puliki Prandadu Pune Aguma. That is, a pup of the tiger will never become a cat. So this Kundandaiyan is a top-notch anesthesiologist, and he was in Malaysia, Saudi, so many areas. He was Tanjavur assistant professor, and just because he wanted to reach high slot in a foreign country, we got a high slot in Tamil Nadu. Because just because he left, I was easily promoted as a professor, because all these seniors have left for foreign countries to earn. Then I got a position. So she is a daughter of Dr. Kundandaiyan, now a professor in Dhanalakshmi Srinivasan Medical College, Perambalur. And she was speaker in this ISA Tamil Nadu conference held at Erode. Even I attended that. And now she is working in Meenakshi Hospital, Tanjavur. He did his MD in Sri Balaji Vidyapith University, and she's a gold medalist. She's a gold medalist in MD, and he won the first prize in poster competition in Nelkan, Tirunelveli, and even Pondicherry, first prize. Her teacher, Dr. Parsardi, used to ask every time. While he participated in a quiz competition, he asked me to attend that. And he had 5 original publications to her credit. When Dr. Chennakesavalu plays volleyball and chess, like me means I will also play chess, which requires high calorie. That is the reason why we are not losing weight. And Indu is interested in playing throw ball. So her husband is very careful with her, because she is good at throw ball. We wish her all the very best. So it will be moderated by Dr. Kumar. S. Kumar is a brand name, S. Kumar. So he will be like a brand ambassador for S. Kumar, and he is one of the few handsome anesthesiologists across the country. So he maintains that quality. Only few people will be blessed with that. So very only handful. I think only handful means it is only 5 handsome people we can locate and the anesthesia fraternity across the country. And the Kumar is one among that. And the ever-ready smile which he has in his face adds charm. His stature. He is practicing cardiac anesthesiology. He is a senior consultant at HOD. But even then he smiles because it is other people's heart which is going to be cut by the surgeon, and he enjoys that. And whenever Kumar anesthetizes, even the dissected heart will dance. So I have seen him performing that central venous cannulation, everything in Madurai Meenakshi is good, and he has dedicated his life to Anesthesia Society also, because he is the scientific committee chairman for the national conference when it was held at Madurai. So he is taking key role in the ISA as well as IACTA. So in Indian Association of Cardiovascular and Thoracic Anesthesiology, see, our people, we cannot cater to this cardiac because it is a high-end procedure. So they will be developing in their own arena, cardiac anesthesiology group. So he was a secretary, he was a treasurer for national IACTA, and he was an executive committee member. So he was the past secretary of IMA also. When he was a secretary in IMA Meenakshi branch, he called me to deliver a lecture over there. So he is taking part in IMA, ISA, and he is organizing secretary of IACT Con. At the time I called him, he has not answered because he was so busy at that time organizing a conference. So he was the past president of ISA Tamil Nadu. That is also there. So with all his expertise, Dr. S. Kumar is appreciated by the High Court judge also. That High Court judge is retired now. So he is having all credentials and appreciation from various faculty across the country. With this introduction, now Dr. Kumar sir, it is over to you. Please take over.
Thank you, sir, for the wonderful words. Am I audible?
Yes, sir.
Respected academic
Yes,
chairman.
sir.
Yeah, respected academic chairman, Dr. A.L. Meenakshi Sundaram, sir. President, ISA Pthukkottai branch, Dr. Munian. Secretary, ISA Pthukkottai branch, Dr. Kannan. Treasurer, Dr. Hema. And Dr. Muralidhar, sir, one of my mentor in cardiac anesthesia, he has messaged me, he'll join. He's on the way from hospital. Shortly he'll join. And most respected delegates, a very good evening to everyone. At the outset, I would like to thank Pthukkottai ISA branch for the excellent conduct of this Pthukkottai Bhudhan.
Thank you,
As
sir.
the past president, Dr. Suresh, Dr. Periyasamy, they have done an extremely good job. And now Dr. Munian, Dr. Kannan, and Dr. Hema, under the leadership of our great,
Yes, sir.
I cannot use the word beyond the great, great Dr. A.L. Meenakshi Sundaram, sir.
Yes, sir. Yes, sir.
Congratulations to the entire team, Pthukkottai Bhudhan, for consistently conducting 28 webinars in the second edition. First edition, you have conducted 52 weeks continuously in 22-23 session. Now in second edition, you are conducting 28th webinar. This is a really well appreciated Zoom meeting because we also have a lot of Zoom meetings, but online meetings. But I never seen nowadays any of the meetings attended by more than 200. This is one of the meeting with more than 700, 800 crowd and delegates. It is really appreciable. That shows the quality of the meeting. No doubt about it. And one more thing, then the effort behind this meeting is phenomenal. Every week you have to arrange and keep occupying the faculty and then delegates. It is a really appreciable one. It is not for words, I'm telling. Seriously, it is a very tough job because I'm also in the one of the administrative post in the organization, but it is really tough job. A real appreciation to the entire Pthukkottai Bhudhan team. Congratulations. Coming to the great academic chairman, Dr. A.L.M. sir, you all know that he's a great academician, no doubt about it, because I was doing MBBS. When I was doing MBBS, sir was a MD Anesthesia PG in Thanjavur Medical College. From that day onwards, I couldn't, if you ask me that time, do you know any anesthesiologist in Thanjavur? I can say only Dr. A.L.M. sir, because none of the anesthesiologists at that time was outspoken and coming out to the forum. Though he was a postgraduate, he was doing extremely well, good academics at the time itself. From then I was in association with the sir, but he's a great academician, no doubt about it. Wherever you talk, you will blast it. Number two, he's a great administrator. He has proven 13 years of administrative experience as a dean and director of medical education in charge. Director of medical education. So those 13 years of administrative skills has proven that is beyond comparable administrator. And whoever heard about his talks, just you would have witnessed that introduction of speakers, and the moderator itself has shown that he's a very good communicator and good orator. Whatever topic, whether in anesthesiology, whether in Tamil, or whether in medical legal issues, whatever the topic, is a phenomenal orator. And you all know that he's an excellent Tamil poet, passionate Tamil poet. So with this, I salute sir for the effort to conduct this Pthukkottai Bhudhan for the benefits of all the delegates and postgraduates all over India. Thank you very much for the opportunity, sir, for the Meenakshi team of doctors. We'll move on to the topic. The topic today assigned is cardiac patient coming for non-cardiac surgery. Some of the pearls was given by our president, Dr. Munian sir, and everyone knows that cardiac disease is increasing with the increasing age. So obviously, many of the patients will come for anesthesia with the cardiac disease. In that, we have chosen 3 topics today. So many of the topics discussed already. So we have chosen valvular heart disease patient coming for non-cardiac surgery, number 1. Number 2, congenital heart disease patient coming for non-cardiac surgery, cardiac surgery. And number 3 is a little away from that routine talks, regional anesthesia in thoracic and cardiac surgery. So for that, we have excellent speakers, which was very elegantly and appreciably introduced by our academic chairman, Dr. A.L.M. sir. Dr. Indu Kundandaiyan. Kundandaiyan sir also my teacher. So Indu Kundandaiyan is going to talk on valvular heart disease, patient coming for non-cardiac surgery. And next, Dr. Chennakesavalu, my good friend from Thanjavur Meenakshi. So he's also going to talk about congenital heart disease patient coming for non-cardiac surgery. And third, our good friend and now joined as a DRNB cardiac anesthesia, Dr. Siva Prasath, who is with me as a resident, but he's more than a resident. He's going to talk about regional anesthesia in cardiac surgery. So with that, we can move on to the topic. Any queries, please put on the text chat box. We are happy to answer all the queries. Whatever the clarifications, we are ready to take it. With this, a few words, I invite Dr. Indu Kundandaiyan from Thanjavur Meenakshi Hospital. She's a very good orator. I welcome Dr. Indu to proceed with the valvular heart disease patient coming for non-cardiac surgery. Indu, please.
Yes, sir. Good evening, everyone. Thanks to Pthukkottai Bhudhan team for giving me this opportunity. Special mention to A.L.M. sir for the warm introduction, and thanks to Kumar sir for. So the topic is anesthetic management for valvular heart disease who's going to undergo non-cardiac surgery, that is NCS. So with the blessings of the institute where I have studied and where I have worked, I'll begin my presentation. So valvular heart disease are categorized into two types. One is forward lesion and the other is backward lesion. So the forward lesions are pressure overload conditions, which are mitral stenosis, aortic stenosis, tricuspid stenosis, and pulmonary stenosis. The backward lesions are volume overload conditions, which consist of mitral regurgitation, aortic regurgitation, tricuspid regurgitation, and pulmonary regurgitation. So we'll be focusing on two conditions coming for two non-cardiac surgeries as a case scenario. So when the valve does not open all the way, not enough blood pass through, it is a stenotic lesion. When the valve does not close all the way, the blood will leak backwards. That is regurgitation. So whenever we talk about non-cardiac surgery, who are having cardiac disease, we have to risk stratify them according to the surgery, then according to their disease. So how do you stratify these patients? Low risk non-cardiac surgery and elevated risk non-cardiac surgery. Low risk non-cardiac surgery will be superficial surgeries, that is plastic surgeries, ophthalmic surgeries, thyroid surgeries, breast surgeries, dental surgeries, minor gynecological surgeries, and orthopedic and urological surgeries. The elevated risk surgeries will be categorized into intermediate risk, high risk surgeries. Intermediate risk will be head and neck surgeries, intraperitoneal surgery, kidney transplant, endovascular aortic aneurysm repair, carotid surgeries, major gynecological, orthopedic, urological and neurological surgery. And the high risk surgeries will be lung or liver transplant, hepatic resection, intrathoracic surgeries, peripheral vascular surgeries, duodenal and pancreatic surgery, aortic surgery and adrenal resection, and perforated bowel surgeries. So if you have to classify this valvular heart disease, according to European Society of Cardiology, they classify into three grades: mild, moderate, severe. According to ACC or AHA, that is American College of Cardiology or American Heart Association, they divide into four grades. A is at risk of development, B is progressive lesions, C is asymptomatic severe lesions, D is symptomatic severe. So we'll have two case scenarios. Both are pressure overload conditions. One is mitral stenosis, who's going to come for transurethral resection of prostate. The other is aortic stenosis, who is going to come for total hip replacement. So how do you evaluate these patients pre-operatively? So the assessment should be based on three conditions. One is severity of the cardiac disease, clinically, biochemically, and radiologically. Number two, you have to see the presence of associated major organ system disease involved in these patients. Number three is you have to maintain the cardiac grid in these patients. So coming to the first case scenario, MS for TURP. So when you see the etiology, most common cause is rheumatic fever, that is rheumatic heart disease. The other causes, as we know, it is degenerative calcification, endocarditis, and the less common causes are there. This is a normal mitral valve, and when the mitral valve is narrowed beyond the normal valve area, it is called as mitral valve stenosis. So when you see the pathology, which is very important, so when the mitral valve is narrowed, your left atrial pressure will get increased, which will lead to hypertrophy of the left atrium, which will cause increased pulmonary pressure and pulmonary congestion, which will result in reduced O2-CO2 exchange, and finally it will result in RV hypertrophy and right side failure. These are all backward symptoms. When you come to the forward symptoms, it is a decreased blood flow to the left ventricle, decreased cardiac output, and you will have a left ventricular hypertrophy. And because of this atrophy, and because of this, the manifestation will be fatigability. So decreased cardiac output is the least manifestation, last manifestation, which will be manifested by low effort tolerance, easy fatigability, and syncope. When you see the increased LA pressure and pulmonary hypertension symptoms, it will be pulmonary congestion, which will lead to dyspnea, orthopnea, cough and hemoptysis, recurrent pulmonary infection, and pneumonia. When you come to LA enlargement, if you have palpitations, the patient is in atrial fibrillation, they are more prone for thromboembolic events, and the hoarseness of voice due to compression of recurrent laryngeal nerve can happen by an enlarged left atrium, and finally result in RV hypertrophy and RV failure, which will manifest as chest pain because of RV ischemia, And right heart failure symptoms as abdominal distension, pedal edema, and right hypochondrial pain. So what are the signs in these patients? They'll have mitral fasciitis, low volume pulse, cold extremities, irregular pulse if AF develops, increased respiratory rate, and all the features of right heart failure, ascites, tender hepatomegaly, and pedal edema, pleural effusion, raised JVP, and left parastinal heave, tapping apical impulse, palpable P2, and diastolic thrill over mitral area. So on auscultation, S1 will be loud, P2 will be loud if severe pulmonary hypertension is present due to mitral stenosis. And opening snap is an additional sound which will be heard after the A2 component of the second heart sound. This is forceful opening of the mitral valve when the pressure in the left atrium is greater than the pressure in the left ventricle. So that is opening snap. When you see S2-OS gap is minimal, then the stenosis lesion is severe. A mid-diastolic rumbling murmur with pre-systolic actionation is also will be heard after the opening snap. This murmur is a low-pitched sound. It is best heard with the bell of a stethoscope, as we all know, at the apex in the left lateral decapitated portion. But this pre-systolic actionation will be absent in AF. Murmur may disappear in severe MS due to low cardiac output. So coming to the investigations, we have to see the ECG, which will have left atrial hypertrophy, may cause P mitral bifid appearance of P waves in lead 2, lead 3 AVF. P wave may be more than 120 milliseconds. AF absent P waves airing RR interval, RVH or right axis deviation or RBP, as like this in the picture. So the chest X-ray, classical sign of straightening of left border of heart, and this left atrium will displace the left atrial appendage, which is shown by the red arrow. On the right side of the heart, you can see a double density sign which consists of overlapping of LA and RA, which is indicated by white arrow. And the left main bronchus is elevated by enlarged left atrium, which is indicated by the blue arrow. So when you assess echo, you have to see the etiology, morphology, severity, what is the treatment intervention, how is the valve, how is the leaflet mobility, flexibility, how is the leaflet thickness, leaflet calcification, subvalvular fusion, and appearance of commissions. And we have different scores, Wilkins score and Paddle score. And you have to see the size of left atrium. And you have to look for a thrombus in NLA. And you also have to search for the any other associated valvular lesion and its severity. This is all detected by transthoracic echo, but transesophageal echo is more sensitive and specific for LA thrombus. So when you medically manage this case, they will be put on diuretics to relieve the pulmonary congestion. Beta blockers and calcium channel blockers will be put to prevent tachycardia, and anticoagulants like warfarin, rate control drugs like beta blockers and digoxin. AF with unstable hemodynamics who may require cardioversion. And the surgical options are balloon mitral valvotomy, surgical valvotomy, mitral valve repair, and mitral valve replacement. So once you categorize and pre-evaluate, you have to see the severity of mitral valve stenosis, which is categorized by different parameters. Once you do that and categorize at mild MS, they can undergo NCS, that is non-cardiac surgery. When they are moderate to severe, if they are symptomatic, yes, they have to undergo percutaneous mitral commissionotomy. If they are not symptomatic, then you look for the pulmonary artery pressure. If it is more than 50, then go for a PMC. If it is less than 50, you can undergo NCS. So what are our goals? We have to maintain the hemodynamics. So we'll target on 5 things. First is heart rate. Tachycardia if you produce, there is a less time for ventricular filling. So the end diastolic volume will be decreased, stroke volume will be decreased, cardiac output will be decreased. So what is our goal? You should avoid tachycardia. So what is the rhythm? You should maintain sinus rhythm. If A is there, effective atrial contraction is lost, no poor atrial quick. So again, EDV will be decreased, stroke volume will be decreased, cardiac output will be decreased. So our aim is to maintain the sinus rhythm. So when you come to the intravascular volume, if it is increased, it will again increase pressure and it will precipitate congestive heart failure. If it is decreased, it will decrease end diastolic volume again it will decrease the stroke volume. So our goal is to optimize the intravascular volume. Number 4 is SVR. If you decrease SVR, you get hypotension, you get a compensatory increase in heart rate, it will further worsen. So goal is avoid decrease in systemic vascular resistance. In PVR, it is increased by hypoxia, hypercarbia, acidosis, and lung overinflection. If it is increased, right heart pressure will increase, precipitate the heart failure again. So avoid increase in pulmonary vascular resistance. Contractility is not that much affected in mitral stenosis. So what is our hemodynamic goals? Avoid tachycardia, maintain sinus rhythm, optimize the intravascular volume, avoid decrease in the SVR, avoid increase in the PVR. So this is the perioperative rhythm control for patient with MS. If digoxin is available, go with it. If short-acting beta blocker only is available, go with esmolol. Calcium channel blocker means verapamil and diltiazem. If not, then amiodarone. So coming to the surgery, this patient MS has come for TURP. So TURP is a transurethral resection of prostate. Whenever you do a risk stratification, you classify into patient, surgery and anesthesia. So far we have considered patient factors. Now we are going to the surgical factors. The prostatic volume you have to see, see the duration of resection, you have to see the recognition of TURP complication, you have to see what irrigation fluid is being used. What is the concern with anesthesia? It's depend upon the severity of mitral stenosis by assessment on cardiopulmonary reserve, clinically by METs and breath holding time, and other examination findings and echo findings. And the position for this surgery is lithotomy, which is add a specific concern to us in this case, on the extent of deafferentation which is required for this prostate surgery. So we again have to go in ahead with subarachnoid block or general anesthesia. Points in favor of subarachnoid block is we get a better hemodynamics if it is mild to moderate with a minimal resection time of 1 hour for TRP. And recognition of TRP complication is easier with the subarachnoid block. Points in favor of GA, we have a controlled hemodynamics in a severity of mitral stenosis lesion, but very difficult to recognize the TRP complication. Always beware of patient, surgical as well as anesthesia factors in related to any complication in any case. So how do you risk reduce? So once you stratify the risk according to all these factors, you have to do some risk reduction strategy. You optimize the patient to near normal physiology, what is feasible for this patient, and damage control surgery to relieve the pathology, what is possible and needed for this patient, and anesthesia, limit to subarachnoid block for TOP if possible, and the choice of analgesia is very important to prevent the perioperative complication. So when you see mitral stenosis for TURP, if it is mild and moderate, better to go with subarachnoid block with the routine bupivacaine heavy or levobupivacaine heavy with an adjuvant, probably fentanyl or buprenorphine, what we use nowadays. If it is a severe stenosis, it's better to go ahead with the general anesthesia with appropriate drugs. But better to secure an invasive lines before any anesthesia procedure for this kind of patients. So now coming to case scenario number 2, which is aortic stenosis for total hip replacement. This patient, blood is unable to flow freely from the left ventricle to the aorta during aortic stenosis. So, and they are more risk for major adverse cardiac events. So, etiology, most common, it will be present in the old age, above 70 years. And in infants, it can be congenital aortic stenosis or congenital subvalvular, supravalvular or valvular. In middle age, it will be calcification and fibrosis and rheumatic in some patients. In middle age to elderly, it will be senile degenerative, calcification and rheumatic cause. So what is the pathophysiology? You get a stiffening and narrowing of the aortic valve, which will lead to left ventricle hypertrophy, which will compress the coronary arteries, which will decrease the O2 supplies and increase the O2 needs, and probably resulting in myocardial ischemia, which manifests as chest pain, and also result in decreased cardiac output. And it's an incomplete emptying of the left atrium, which leads to pulmonary congestion and right-sided heart failure. So aortic stenosis is always inset with coronary artery disease or chronic kidney disease. Ideal target is also to prevent coronary ischemia. It's a fixed cardiac output status. So how do they manifest? Usually they are asymptomatic, even it is mild, moderate or severe asymptomatic. Sometimes they present with ASD clinical type, that is angina, syncope and dyspnea, which is more present during exertion, and sudden death history and episodes of acute pulmonary edema. Signs, you have ejection systolic murmur, slow rising carotid pulse, thrusting apex big LV pressure overload and narrow pulse pressure, and signs of pulmonary venous congestion which manifests as crepitation. So you have to see ECG, look for LVH, LBB. In chest X-ray, you look for enlarged LV and dilated ascending aorta and calcified wall. In echo, you look for a calcified wall with restricted opening and hypertrophy of LV, and measurement of the severity of the stenosis, and if required cardiac catheterization to grade it between LV and aorta. So medically managed, if they are asymptomatic, they keep under review. If a moderate or severe stenosis, they evaluate every 1 to 2 years with a Doppler to detect the progress of the severity of the disease. In symptomatic severe aortic stenosis, they do a valve replacement. In congenital aortic stenosis, they do aortic balloon valvuloplasty. Atrial fibrillation or post-valve replacement with the mechanical prosthesis, they start on anticoagulant. So what is the goals in this case? Again, 5 things. Heart rate. If you increase the decreased LV filling time, decreased EDV, decreased SV, decreased LV ejection time, decreased stroke volume, decreased coronary perfusion, again ischemia. But if you decrease the heart rate, it will be again increased LV filling, but ejection is limited due to stenosis, overfilling of the LV, which will increase in LV-LA pressures. So it's better to avoid tachycardia or bradycardia. So in rhythm, junctional rhythm may be present, or sinus rhythm may be present, or AF also may be present. Maintain sinus rhythm is our goal. How do you maintain the intravascular volume? If you increase the intravascular volume, you have an increased endodiastolic volume, but cannot be ejected. Overfilling, LV-LA pressures again rise. If you decrease the intravascular volume, again you get a decreased endodiastolic volume, decreased stroke volume. The goal is again optimize the intravascular volume. So what is SVR? If you decrease, it cannot be compensated. So you get a refractory hypotension. Better avoid decrease in SVR so that hypotension is avoided. In PVR, pulmonary pressures are not significantly raised as like in MS because of LV hypertrophy. So contractility, don't decrease it, further reduce and stroke volume will happen. So goal is avoid myocardial depression. So what are the hemodynamic goals? Avoid tachycardia or bradycardia, maintain the sinus rhythm, avoid the hypotension, decrease in SVR, optimize the intravascular volume, avoid myocardial depression. So coming AS for THR, that is totally placement. So what are the considerations in this surgery? Patient age. Mostly these patients will come for osteoarthritis hip or avascular necrosis hip. So most old age will come, severity of the lesion you have to see, and organ dysfunction you have to see. Surgery wise, you have to see the duration, blood loss, what is the stress of surgery, what is the extent of deafferentation we needed with an RA, what are the factors specific to this surgery. This will be put in lateral position, and using of cementing, uncementing is a critical step in this surgery. So anesthesia, you have to take care of the circulation and other organ dysfunction. So how do you risk reduce strategy in these kind of AS patients for THR? In patient, you maintain the circulation by targeting the hemodynamic goals, what we have mentioned. In surgical, you take care of the positional care. When you take an invasive lines, you take in the dependent, take care of the IV lines, and when you position and take care of all the bony structures, and watch each and every surgical step, including the broaching of the stubulum, including the cementing process, which will lead to altered hemodynamics. And in anesthesia, you should modulate some pain control strategy in these kind of patients by regional nerve blocks like pericapsular nerve group block or suprainguinal fascia iliaca block, which is feasible for these patients. So if you take an AS, you have to see again whether it is a severe or mild or moderate. In these, the ACC or AHA and EC guidelines say symptomatic severe AS for whom AVR surgery does not pose a high operative risk, and NCS, that is non-cardiac surgery, is not time sensitive, then you better go with surgical aortic valve replacement or transcatheter aortic valve implant, which is recommended before NCS. But if it is symptomatic severe aortic stenosis for whom NCS is intermediate to high risk and time sensitive, and AVR is possessing a very high operative risk, nowadays we practice preferred TAVI, which is preferred over SAVR before NCS. For symptomatic severe aortic stenosis for whom NCS is intermediate to high risk and time sensitive, neither SAVR or TAVI is feasible, balloon aortic valvuloplasty may be considered before NCS as a bridging therapy until planned definitive aortic valve repairment. So aortic valve intervention in asymptomatic patients with the severe AS, a normal LVF, undergoing low to intermediate high risk. NCS is not associated with large volume fluid shift. Yes, proceed. Asymptomatic patient with severe AS undergoing high risk non-cardiac surgery, the decision to perform AVR has to be made individually based on patient's clinical presentation and comparison of the risk profile of AVR versus NCS. So when you take MS or AS, they will be put on anticoagulant whenever it is required, if it is a mechanical heart wall. So before intervention, what you have to do, after intervention, what you have to do. Before intervention, you have to stop the vitamin K antagonist 5 days, and the next day, 4 days after the before the intervention, start UVH, that is unfractionated heparin or low molecular heparin, as a bridging therapy, and stop it accordingly. If it is unfractionated apparent, 6 hours before. If it is low molecular apparent, it is 24 hours. After intervention, again bridge it. When 12 to 24 hours after surgery, start the unfractionated heparin and start it and bridge it if it is required. Stop concomitant unfractionated low molecular once INR is reached more than 2 in patients with aortic valve and once INR is more than 2.5 in patients with mitral valve. So in case of patients undergoing urgent NCS with biological heart valve on dual oral anticoagulant therapy on lifelong, anticoagulation treatment can be stopped 2 days before intervention. So you have to manage and titrate and balance and overlap it. So hence elective NCS should be scheduled for a minimum of 3 months after valvular bioprosthetic therapy. For urgent NCS within 3 months of valvular repair or for patients on lifetime anticoagulation therapy, the perioperative modification of anticoagulation treatment with bridging therapy is required. So at last, what not the least, IE prophylaxis, whether it is indicated or not indicated, see whether it is fits into this criteria. If they have a prosthetic cardiac wall or prosthetic material, if you have previous infective endocarditis, if you have a congenital heart disease, if you have a cardiac transplant, and you see what type of surgery and see whether it is recommended. So the take-home message is you have to thoroughly examine, evaluate the valvular heart disease. Then you evaluate the valve function. You look for the presence of concomitant cardiac and relative non-cardiac disease. And then you risk stratify for moderate to high risk non-cardiac surgery, which carries a more perioperative mortality and complications. The need of valvular heart disease correction before NCS should be weighed and done if necessary. Anticoagulation therapy modification should be done before any elective NCS. So this is our team. This is our postgraduates. We are always supported 24/7 by the ICU teams and as well as the cardiology and the CTVS team. And we are the first in the Delta region to have an DNB in anesthesiology. Thank you.
Yeah, thank you, Dr. Indu. It is a very good presentation. The two have taken up the 2 case presentations along with the evaluations. I think we can take up the questions at the end lesson.
Yes, sir.
It's at the end only.
Okay. So in a nutshell about valvular heart disease patient coming for non-cardiac surgery, I quickly come out with 2-3 points. You have to look at the valvular lesion, number 1. Number 2, the risk of surgery, as she mentioned about low risk surgery and intermediate risk surgery and high risk surgery. So those 2 things has to be combined for evaluation and risk stratification to proceed further. She has taken 2 cases, MS mitral stenosis patient coming for TURP surgery, that is TURP. In that, whenever there is a mitral stenosis of mild and moderate category, we can proceed for the proposed surgery. Whenever there is a symptomatic severe mitral stenosis, better to undergo valve intervention first and then proposed surgery if time permits. Number 2, about the choice of anesthesia for this mitral stenosis and TURP, that is individualized and pros and cons she has clearly put up. The next case is about aortic stenosis and total hip replacement. In that also, mild, moderate aortic stenosis, you can proceed for proposed surgery. And severe symptomatic aortic stenosis, better to undergo valve intervention first, then proceed for the non-cardiac surgery. So that is clear 2 case presentation, and choice of anesthesia is always individualized. Any pros and cons we can discuss further. With this, I think we can move on to the next case, next presentation. That is congenital heart disease patient coming for non-cardiac surgery. For that, I invite Dr. Chennakesavalu, consultant cardiac anesthesiologist from Thanjavur Meenakshi Hospital. Chennakesavalu, please. Dr. Chenna, please. Chenna is free still. Dr. Chennakesavalu.
We can go to Dr. Siva Prasath.
Yes, sir.
Yeah, we can.
What happened? You did not come in between. That is what.
Sir. I think sir is trying.
Chennakesavalu is trying. That is a started screening. That
Yeah,
is
Dr. Chennakesavalu, you stop screening your stop share. Dr. Chennakesavalu, you please stop sharing your screen.
Dr. Chennakesavalu, is it audible?
Yeah.
Yeah, then we'll move on to that next talk on regional anesthesia for thoracic surgery by Dr. Siva Prasath. As I introduced earlier, he was 17 years as a professor, now become a DRNB resident at Meenakshi Mission Hospital. He's a good orator and very passionate teacher also for the MD postgraduates in Madurai Medical College. Over to Dr. Siva, please.
Good evening, sir.
Good evening.
Dear academic chairman, thank you very much for the kind words of introduction. And good evening to the moderator and my mentor, Kumar sir. Good evening to the president and secretary of Pthukkottai City Branch. Good evening to all residents. Today, the topic given to me is regional anesthesia for thoracic surgery. So why is it important? The pain of thoracic surgery is very intense. As we go through the slides, you will understand that why it is so intense and why it harms the patient more. And because of this, it requires high dose of opiates and a deep anesthetic plane. Once you go into this with GA, high opiates and deep anesthetic plane, there will be always some delay in recovery, and that will give out some pulmonary complications. See, this patient has already had high doses of drugs, and with this pain, he won't be able to do the physiotherapy. There will be some pulmonary secretions. So all this together will increase the length of hospital stay and discharge. So there comes the ERAS. Nowadays, we are very fond of these words, ERAS. And the ERAS protocol demands the use of multiple analgesia, that is, reducing the opioid usage, more paracetamol, NSAIDs, and along with the regional anesthesia. That is why we have to understand this regional anesthesia techniques very nicely and implement them in the routine practice. And to add upon, the era of just epidural blocks and blind intercostal blocks have ended with the onset of USG guided facial plane blocks. And though we have so many facial plane blocks, they can be rarely used as a sole anesthetic. We will have to supplement them with GA for thoracic or cardiac surgery. So in this topic, I'm going to talk about relevant anatomy, possible techniques, or whichever is possible for thoracic or cardiac surgery, the type of procedure, their pros and cons, and evidence for that. And all my techniques are only ultrasound gate based, and all my methods are either in the parasagittal plane or transverse plane, and I have presented only in plane technique because that is the safest method. So this is the transverse in plane where it is parallel, and the needle orientation will be always capillate to caudal, or a transverse plane where the needle orientation will be from medial to lateral or lateral to medial. Coming to the innervation of anterolateral chest wall, thorough understanding of what innervates the chest wall and the deeper structures is so important, because the chest wall is innervated with variety of nerves. You can see here on one side there is lateral branches of the thoracic intercostal nerves. Medially, there's medial branches of thoracic intercostal nerves. So both are totally different. So when I talk about the intercostal nerve anatomy, you'll understand why I have given importance to lateral and the medial branches. And the superior part of thorax is innervated by cervical plexus, that is supraclavicular nerves, and the medial uppermost part is by brachial plexus, that is the nerve to serratus anterior thoracodorsal nerve, the intercostal brachial nerve, and the medial cutaneous brachial nerve form. All this together, they innervate. That is why any incision on the thorax is going to be very painful. They are going to carry all these impulses to the head, and this patient is going to have a splinting in breathing and a difficulty in recovery. So we have to understand the anatomy of a typical intercostal nerve. The typical intercostal nerve means intercostal nerve 3 to 6. But whenever we talk about thoracic surgery, at least a T2 to T6 blockade is mandatory. Even though we can, we could be a single rib resection or a single plane surgery, T2 to T6 is mandatory to cover all the anesthetic requirements. So this is a typical spinal vertebra where we can see the spinal cord here, that the thoracic nerve root is coming out, and once it comes out, it goes into the paravertebral space. So here the nerve rootlet contains both anterior and the dorsal rami together, and the paravertebral space is bounded anteriorly by the parietal pleura and the sympathetic chain. Medially, we have the vertebral body and the intervertebral disc. Posteriorly, you have the superior costotransverse ligament. Here we have the transverse process and the superior costotransverse ligament. So all this together form the boundaries of the paravertebral space. And once it exits the nerve root exits the paravertebral space, it first divides into a ventral and a dorsal ramus. The dorsal ramus will supply the paravertebral muscles and spine only. This is a very important point, because if you block the dorsal ramus, you will have a narrow strip of analgesia on either side of the posterior midline, not anywhere in the anterior. So you should be reminded that dorsal ramus supplies the paravertebral muscles and the spine only. That's it. And the ventral ramus, it will pierce the intercostal membrane and move forward in the intercostal space till the sternum. So this is the ventral ramus going through the intercostal space in between the internal and the innermost intercostal muscles. And while doing so, it will give plenty of collateral branches to the ribs and muscles. This is an important point. So because of this only, rib fracture is very painful. Collateral branches is richly innervating the ribs and muscles. And as you can see here, the innermost and internal intercostal muscles. Above that, you have another muscle, that is the serratus anterior muscle. So somewhere in the near the axilla, the anterior intercostal nerve will give a lateral intercostal branch. It will cross the intercostal, it will cross the serratus anterior muscle, and then go on to divide into anterior and posterior branches. This lateral intercostal nerve will supply the skin and soft tissue of the lateral chest wall. It does not supply the rib or intercostal muscle. It will supply the skin and soft tissues there. So this is going to be some importance when we talk about a serratus anterior plane block. And lastly, the anterior intercostal nerve goes forward. It goes in between the intercostal and the transverse thoracic muscle. It is deep to the pectoralis major. It will go near the sternum, and it will give off a shooting branch. It will divide into medial and lateral branches so that it innervates the anterior chest wall in the midline. So we have three distinct areas. The dorsal ramus supplying the posterior paravertebral area, the lateral branch supplying the lateral chest wall, and the anterior nerve going till the sternum and then dividing into medial branches, giving a strip of innervation in the anterior midline. So these three are totally distinct areas. I'm sorry if my diagram is not neat, but I just wanted to make sure the postgraduate understand the course of this nerve and why all these blocks are so different in their character of giving analgesia. So if you look at this, the star here, if you block the midline, you will have central axial block, and laterally you can put some blocks in the paravertebral area. It will give dense analgesia. The whole hemithorax, both dorsal and the ventral ramus will be blocked. You can also do some blocks called paravertebral by proxy or posterior chest wall blocks. These blocks depend on the drug diffusing into the paravertebral space through some spaces and then only acting. So we can give paravertebral, or if you're not confident on that, you can give paravertebral by proxy blocks. Then you can do intercostal nerve blocks. Remember, the anterior intercostal nerve can be blocked, but we should be careful to block it in the most posterior area so that the whole intercostal nerve is blocked. You can also do serratus anterior block to block the lateral intercostal nerves so that the soft tissue of the lateral thorax is blocked. And last, the parasternal blocks for midline sternotomy, they are 2 in number, pectointercostal facial and transverse thoracic muscle plane block. If you do this only the midline, anterior midline will be blocked and no other place. So each one we'll discuss slowly. Coming first is the central block, the thoracic segmental spinal anesthesia. So we always had a aversion to do this because of cord damage fear, but it was alleviated by, you can see this MRI picture, you can see very well that the spinal cord, when it comes down near the thoracic vertebra, it becomes more anterior. So you can see the dimensions also. Anterior posterior dimension, it is in T1, it is 4.19, but near T4, T5, the spinal cord has gone far away from the posterior midline, 6.17 millimeter. And again, when it comes down to lower thoracic, it has become 4. So even if you insert a needle through the dura, you will have to reach a longer, extra 2 to 3 centimeters longer to actually give a puncture on the cord. So it is very difficult to puncture. The next thing is that if you look at the spinous process of all the thoracic vertebrae, they're very angulated. So at 50 degrees, if you introduce a needle, it takes a more longer distance to reach the cord. So the fear of cord damage was alleviated. And next we had concerns of hemodynamic instability. So here also, if you give very low amount of drug, it is going to give a good block because the thoracic nerve roots are thin and there is less CSF volume, and the drug doesn't spread down. See, whenever we give a spinal analgesia, it doesn't go and block at the level of the spinal cord. It only blocks at the level of rootlets. So the low dose stays there in the thoracic component and it will not produce lower limb analgesia or systemic vasculation. So all this together made thoracic segmental spinal analgesia a possibility. But remember, it have to be very, very careful. Both the cord damage and all the complications are possible, but it is still considered safe. Coming to epidural analgesia, we have pros and cons. The pros being it gives bilateral complete analgesia and it can be a sole anesthetic method. I remember the first awake cardiac surgery in Tamil Nadu was done by Kumar sir with the sole anesthetic method of epidural. Many have tried, but it's very difficult. Still, you can use it as a sole anesthetic method because of its complete analgesic nature. And it has advantage of a catheter. You can put a catheter and you can prolong the analgesic duration. It has been shown to consistently give improved outcomes. And even in pediatrics, you can use caudal epidural anesthesia to have thoracic. Even if you give a small dose of morphine, it will reach very high levels. But coming to the downside, it is always accompanied by hemodynamic instability. And in cardiac surgery, we always have a problem of epidural hematoma. Though the projected incidence is 1 in 3,500 or 1 in 12,000. One patient for us is a very important patient. So every time you will have to follow the ASRA guidelines of stopping antiplatelet and anticoagulation. You should not use more than 2 attempts to do an epidural. More than 2 attempts will increase the chance of bleeding. Always use episure or epiballoon rather than loss of resistance syringe, because once the needle enters into the epidural space itself, the balloon will decompress. So that by that you can avoid going more near the dura or the cord, and catheter should not be placed more than 5 centimeters. Once we get a loss of resistance, it's very natural for us to put a long catheter inside and then slowly pull it out, but it should be avoided. We should carefully note at what centimeters you have got the epidural space. Only 5 centimeters is the safe limit. Coming to paravertebral block, I already told you the boundaries of paravertebral space. I'll repeat it again. Anteriorly, it is bound by parietal pleura, medially by the thoracic vertebra, posteriorly by the transverse process and the superocostal transverse ligaments. So this is the boundary. So it is as good as epidural. Once you can see in this picture, if you deposit the drug here, all the nerve rootlets are blocked, the sympathetic nerves are blocked, both dorsal and ventral ramic get a good volume of drug. So it is as good as an epidural. Both you can use it for unilateral and bilateral also. Many times we have given bilateral blocks. It can be done. The main advantage is other blocks has to be used with ultrasound guide. Here you can do a blind block also. We have done by walking over the lateral process and just entering into the superior transverse ligament, depositing the drug. It's a very useful method where ultrasound facilities are not there. And because it is a potential space, catheter also can be inserted. And usually in pediatrics, though it needs a lot of training, it is very useful for especially in cases of PDA. In PDA ligation, we have used many blocks, but the most consistent and the best block was paravertebral block. The problems with paravertebral block is sympathectomy and risk of epidural splinter. So close to epidural, the drug just goes in and it produces a bilateral block when it is not needed. So these are the downsides of paravertebral block. I'll show videos when it comes. So coming to posterior chest wall blocks, there are a lot of blocks which have been developed by different names. Still block, the midpoint of transverse process to pleural block, the costa transverse foramen block, retrolaminar block, erectospinal block. Out of all these blocks, I think erectospinal and MTP block have been standing the test of time. We'll see how this helps in producing analgesia in the chest wall. You can see the green one is the paravertebral space, and these blocks are so close to it but not on the green. So giving a drug there has to seep through the spaces. So this is the anatomy of how the drug from the erector spinal plane goes into the paravertebral space. So here we have two transverse. In the first picture, we are showing two transverse processes and the intertransverse ligament in between. So above that, posterior to that, we have the erector spinae muscle. We are depositing the drug in between the erector spinae muscle and the transverse process. Now, what happens is the drug slowly crosses the intertransverse ligament first, and then the superior costal transverse ligament, and then enters the paravertebral space. In the next diagram, we have shown this in like an ultrasound real time. The first ligament is the intertransverse ligament, then it has to cross the costal transverse ligament, then go into the paravertebral space. So once you have deposited the drug in the proxy paravertebral space, it traverses by three different routes: the costa transverse space, the lateral slit that is between the costa transverse ligament and the intercostal membrane, and there's a medial slit through which the ram enter the paraspinal space. Through all these three routes, the drug can seep from the posterior element into the anterior, that is the paravertebral space, and produces its effect. But the thing is, it's easy to perform wide range of analgesia, and there is always a risk of blocking the dorsal ramus only. See, suppose the drug does not go into the paravertebral space, this block is not going to work. Suppose you have done a thoracotomy and you are confidently giving erector spinae. For that patient, if the drug does not go into the paravertebral space, then it will be a failure. So that is why in early steps, you will have to learn the erector spinae block, then go on to the MTP block, that is the midpoint of transverse process block, and then you have to practice paravertebral. So only once you go this way, paravertebral blocks will become very easy and safe. So this is the erector spinae and MTP plane. In this diagram, you can see that there are three muscles: the trapezius, rhomboid, and erector spinae muscle, below which is the transverse process. In between two transverse processes is the intertransverse ligament. We have to bring the needle in plane and lift the erector spinae muscle and allow the drug to spread over the intertransverse ligament. I have a video there. This is the ESB plane, and that is the MTP plane. So here you can see that the first video, we am scanning over the rib. The rib is round in shape. I'm going slowly, medially. I'm going. You can see that once the transverse process is reached, the ribs become box shaped. So that is the place where we would stop and look for the intertransverse ligament in between the two transverse processes. The next video, you can see that I'm bringing my needle in plane, and it has reached the intertransverse ligament. I'm hydrodissecting, slowly lifting the erector spinae muscle. So here you can see that after 10 ml is given, the erector spinae muscle will lift up. Can you see it has lifted up? So this is the way you have to give an erector spinae block. Coming to paravertebral block in the parasagittal in-plane approach, see, I've kept the transducer parallel to the spine. Oh, I can see two ribs in place, and once I move, it will become two transverse processes. In between these two transverse processes, I have intertransverse ligament and the superior costal transverse ligament. My needle has come in plane and it has reached the superior costal transverse ligament. Now see, I'm slightly giving the drug, the pleura drops down, and I'm able to enter into the paravertebral space nicely and give the drug, the pleura is dropping down. So this is how you should give a paravertebral block. Slowly, if you learn ESB, MTP, then you can learn the paravertebral block, going and piercing the superior costal transverse ligament. In paramedian transverse scan, you can see that this is much more safer block. So I have kept the scan in the transverse process. You can see this transverse process in the medial side. and the paravertebral space here, can bring the needle from lateral to medial and approach the paravertebral space. So erector spinae block has become a very popular block in that it's so easy to perform and it has got intermediate results. Many studies have given good results. But there was one study by Manoj Kumar Kamarkar. It's actually not a study, it's a comment where he highlighted the place where the erector spinae block spreads. And he says that it is a very unreliable block for thoracic surgeries. It may be practiced, but it might not give good results. So we should always try to go for paravertebral block. Coming to lateral chest wall facial plane blocks, we have intercostal nerve and the serratus anterior. Due to time constraints, I'll keep myself to the serratus anterior plane block. You can see we are doing a transverse or a parasocial method. The drug is deposited between the intercostal and the serratus anterior muscle, or the serratus anterior muscle and the subcutaneous plane. There are two planes here. I'll show them. The first is the superficial SAP block. The drug is spread in between the subcutaneous muscle, subcutaneous fat, or the latissimus dorsi and the serratus anterior muscle. It can consistently block the T2 to T9 intercostal nerves, the thoracodorsal nerve and the long thoracic nerve. But remember, I already told you the lateral intercostal nerve will only give to the skin and the soft tissue. So this block can only be used for skin and breast surgery or soft tissue surgery, whereas the deep block is between the serratus anterior muscle and the ribs and the intercostal spaces. This will also block the collateral intercostal nerve branches, which will supply the ribs. So in case of rib fracture, you will have to always put the local anesthetic in between the serratus anterior and the intercostal muscle so that the pain is gone. Coming to anterior chest wall facial plane blocks, there are anterior lateral blocks, that is the PEX 1 and 2. This will target the medial and lateral pectoral nerves. The drug is deposited in between the pectoralis major and minor muscle in PEX 1, and between the pectoralis minor and the serratus anterior in PEX 2. Most of the surgeries like breast surgery, minimally invasive cardiac surgery, permanent pacemaker insertion, all that can be done in PEX block. And it can also be a supplement to thoracotomy, intercostal drainage. And in parasternal blocks, we have two blocks, pectointercostal facial plane block and the transverse thoracic muscle plane block. They block the terminal anterior branch of intercostal nerve, which will supply the sternum, and midline sternotomy will become really painless when you give these two blocks. Here, I have kept the transducer in the parasocial plane near the parallel to the sternum. Here you can see that we can see the two ribs there, and the first one is the pectoralis major muscle, intercostal muscle, and one hypoechoic muscle down that is the transverse thoracic muscle, TTM, that is the transverse thoracic muscle. You can either give the block in between the intercostal and the pectoralis major, or equally you can also give, if you're well versed in in-plane techniques, you can give between the intercostal and the transverse thoracic muscle. That also will work very nicely. So there was always fear of pneumothorax and injury to the lima or rima artery. Here I have shown that in midline, when you scan, you can see the sternum. On either side, we have the intermammary artery. So you can also, if you see this in plane, you can also bring a needle here and place the drug there. That is the transverse thoracic muscle plane in the transverse plane block. It's much more safer. It requires little more training, but it will not harm the internal mammary arteries. So coming to summary, the centroneuraxial blocks will produce dense bilateral analgesia with sympathectomy. The paravertebral block will equally produce a dense block, but it will be unilateral and it always has some sympathectomy with it. The paravertebral biproxy blocks or posterior chest wall blocks is very unreliable, but it's very safe and easy to perform. The anterior intercostal nerve, it should be so effective only if done is very posteriorly, because I have already told you going more and more anteriorly will not cover the ribs and the intercostal muscle. So it has to be done as posteriorly as possible. Serratus anterior block, if you want to give it for rib fracture, always try to go target the space between intercostal muscle and the serratus anterior muscle, that is a deep SAP. And if you want to give parasternal blocks, it is only used for sternotomy and not for other thoracic vertebra. And with that, I thank the Pthukkottai ISA academic chairman and my mentor for giving me this opportunity to give a brief insight into the regional anesthesia for thoracic surgery. Thank you very much, sir.
Thank you, Siva, for the excellent, very brief, but you covered everything.
Thank you, sir.
Starting with the anatomy, and then I went up to the 6 major blocks, that is central blocks, that includes thoracic segmental and thoracic epidural, and then paravertebral blocks, proxy, anterior intercostal nerve blocks, serratus anterior blocks, and parasternal blocks. All those things are well in practice. As you said, more than the muscle plane blocks, these paravertebral blocks is taking over, but the evidence is not much for those myofascial planes blocks, but over years it will come up, no doubt about it.
Yes,
As of now, central block have high evidence for thoracic anesthesia, but these myofascial blocks definitely will take over in future with a lot of evidences. I think we'll have a discussion at the end of next lecture. So I invite the next speaker, Dr. Chennakesavalu, who is going to talk on congenital heart disease patient coming for non-cardiac surgery. Chennakesavalu, okay? Okay now? No, please unmute. Shiva, please unshare.
Okay, sir. Sir, I'm sharing.
Siva Prasath, please unshare.
Stop.
Yeah, okay. Just go ahead, Chenna.
Thank you very much, sir.
Yeah, no problem.
I thank Dr. Kumar sir and Meenakshi Sundaram sir for giving opportunity to present here in this section. And I sincerely apologize for the inconvenience caused by me. And my topic is on anesthesia implication in congenital heart disease patient coming for non-cardiac surgery. And congenital heart disease, they're broadly classified into 2 types. One, it is acyanotic, other one being cyanotic. Acyanotic, it is further divided into two classes. One, it is those associated with increased pulmonary blood flow, which includes atrial septal defect, ventricular septal defect, patent ductus arteriosus, and atrioventricular canal defect, and those associated with obstruction to outflow from ventricle, which includes coarctation of aorta, aortic stenosis, and pulmonary stenosis. And cyanotic diseases, it includes those associated with decreased pulmonary blood flow, which include tetralogy of Fallot and tricuspid atresia, and mixing lesions, where mixing of oxygenated and deoxygenated blood, it occurs either at the ventricle level or at a great arteries, which include transposition of great arteries, total anomalous pulmonary venous connection, truncus arteriosus, and hypoplastic left heart syndrome. With advancement in medical technology, many of these patients with congenital heart disease, they are surviving into adulthood. Therefore, it is not uncommon for non-cardiac anesthetists to encounter such patients, either for emergency surgeries or for elective surgeries. Hence, it is imperative for non-cardiac anesthetists to know the pathophysiology of this congenital heart disease so as to provide an optimal and a perioperative care. Since the spectrum of congenital heart disease is very broad, I would limit my talk only to 2 case scenarios. One, it is a classical tetralogy of Fallot child coming for with cerebral abscess coming for emergency burr drainage, and second case being parturiente with atrial septal defect with good functional class, good functional class coming for elective LSCS. And coming on to the first case, the case details includes 4-year-old male child. He has complaints of fever, drowsiness, and altered sensorium since 2 days. And mother gives history of bluish discoloration of tongue and lips since birth. And there is a history of easy fatigability on exertion. That is, when the child is playing, he gets fatigue very early, and it was relieved by assuming Namas position. That means the child is having tech spells. On clinical examination, we could see cyanosis, clubbing, and the child was febrile to touch. And saturation was maintained around 80 to 85% on room air. And his hemodynamics were stable. And GCS was 13/15 on admission. And routine lab workup, it showed polycythemia, and D-range INR with an INR of 1.7, normal LFT and RFT, and ECG showed features of right ventricular hypertrophy, and CT scan showed right frontal hypodense lesion with mass effect on frontal horn, and chest X-ray showed classical boot-shaped heart with LV apex upturn due to RVI hypertrophy and decreased pulmonary vascular marking in both lung fields, suggestive of pulmonary oligemia. And what are the findings which are important for a non-cardiac anesthetist in echo? We have to see the VSD size. What is the size of the VSD? Usually in classical TOF, it will be a non-restrictive VSD, and direction of the shunt, whether it is right to left or bidirectional. Patients with predominantly right to left shunt, they have more degree of cyanosis, so that they may develop desaturation very fast than when compared to patient with bidirectional shunt. And concentric RVH. In patients with concentric RVH, there is associated RV diastolic dysfunction, so that these patients, they may not tolerate the fluid bolus very easily. And then level of this right ventricular outflow tract obstruction, whether it is below the pulmonary valve or at the pulmonary valve or above the pulmonary valve. For us, it is for non-cardiac anesthetists, it is infundibular PS which creates more trouble, because it is these patients with infundibular PS who would likely to develop TED spells intraoperatively or perioperatively. And size of PS are very important. Patients with a small PS, that means that they don't have any additional source of pulmonary blood flow, so they are more prone to develop desaturation. Also, in these patients who have small PS, modulation of PVR, it does not have any influence on right to left shunting. And aortic override, it is a component of TOP. That means it occurs because of deviation of aorta anteriorly, so that RV through the VST is directly ejecting the cyanotic blood into the systemic circulation. And we have to look for other source of pulmonary blood flow like PDA and MAPCAS. So in classical tetralogy of Fallot, there are four main anatomical components. One, it is the VSD, which will be usually non-restrictive, that is, it is a large VSD, and right ventricular hypertrophy, and RVOT, right ventricular outflow tract obstruction. It can be either below the pulmonary valve or at the pulmonary valve or above the pulmonary valve, and aortic override greater than 50%. With this anatomy, there is a right to left shunting. So the deoxygenated blood is pumped directly into the systemic circulation. So the patient will have cyanosis and its consequences like polycythemia and derange coagulation profile and decreased platelet count. So our main anesthesia goal in this patient is to prevent or reduce further increase in right to left shunting, so that there won't be any cyanosis. At the same time, we have to keep in mind that we should not completely abolish this right to left shunting, because it may choke the RV and leading on to acute RV failure. This anesthesia goal is accomplished by keeping the SVR on higher side, maintaining euvolemia, and aborting any dynamic RVOT obstruction, and lowering the PV and lowering the pulmonary vascular resistance. And whatever our anesthesia concern in pre-operative room. Fasting should be limited in this child, because fasting predisposes the child to develop dehydration and hypovolemia. Hypovolemia causes reflex increase in the heart rate and contractility, causing increased RVOT obstruction and predisposing to TED spell. So so it is advisable to give clear fluids until 2 hours before the child is shifted to operating room. Or if you have an IVSS, we can start maintenance fluid at 2 ml per kg per hour. And the anxiety, pain and fear associated with IV cannulation, it can also cause TED spell. So how to tackle this? We have to nurse the child in parental presence, and we can administer oral sedatives like chloral hydrate 50 mg per kg, or we can apply unblock cream over the dorsum of the hand prior to intravenous cannulation. All this, they can reduce the incidence of TED spell. And most of the children, they have syndromic association like Down syndrome, Dijor syndrome. So there is a risk of difficult airway, hypocalcemia, and immunodeficiency. Some of these tetralogy patients, they can be on certain medications like propranolol and iron syrup. They can be continued perioperatively. And this congenital heart disease patient coming for non-cardiac surgery, they can be classified into 3 risk groups. One, it is low risk, which includes congenital heart disease, which is repaired, and patient is having normal cardiovascular function and no medication. Or Second good thing, it is congenital heart disease patient who is having no symptoms. Example, it includes ASD and VSD. And moderate risk, it includes congenital heart disease patient who have a residual region after repair and they are on medications. For example, it includes hypoplastic left heart syndrome after initial palliative repair. High risk patients, it includes uncorrected cyanotic congenital heart disease, those patients who are having pulmonary hypertension and ventricular dysfunction and are on medications for ventricular dysfunction or are awaiting heart transplant. If any of these patients in this risk group has additional features like patient is less than 1 year of age or additional comorbidities like CKD, insulin dependent diabetes, developmental delay, or if the risk of a procedure is high like emergency neurosurgery or vascular surgery, thoracic surgery, open abdominal surgery, then the risk it increases by 1 grade. For example, low risk patient is having these features, then the risk it will become moderate. Then what are our concerns in the intraoperative period? Since there is a right to left shunt, strict dearing in the IV lane is mandatory because it can cause paradoxical emboli leading on to stroke, myocardial ischemia, or any other end organ damage. And if you are using intravenous anesthesia, IV induction will be faster. So it should be titrated judiciously, titrated and slowly administered. And since IV induction is faster, this child can develop apnea very fast. So it is better to pre-oxygenate before injecting the drug. And agent of choice for IV induction would be ketamine because it maintains the SVR. And midazolam, it is administered for amnesia, and fentanyl 2 mics per kg bolus, it can be given at induction to blunt the hemodynamic response. Suppose if the child is not having any IV line, inhalation anesthesia, if he is used, then the induction will be very slow. Because of right to left shunt. There is a decreased pulmonary blood flow, so the uptake of anesthetic by inhaled anesthetic by pulmonary blood will be reduced. So it may be necessary to keep higher volume percentage of inhaled anesthesia. But anesthetic should be mindful about using a higher concentration of volatile anesthetic because it can cause drop in SVR very rapidly, leading on to TET spell. The agent of choice would be sevoflurane because it causes less fall in SVR when compared to other inhalation anesthetics. Since this child they have difficult airway card should be ready. And peri-induction, there should be strict avoidance of blood pressure fall, hypovolemia, or any light plane of anesthesia. For this, we have to keep phenylephrine boluses syringes as well as infusion and fentanyl boluses ready. And as Indu madam has already said, this patient is a cyanotic congenital heart disease, so definitely infective endocarditis prophylaxis is recommended. Usually 2 doses of antibiotics is sufficient. We usually administer cefuroxime 25 mg per kg at induction and 4 hours after surgery. And muscle relaxation would be with vecuronium because it is hemodynamically stable. Pancuronium, it can cause tachycardia and it can cause TET spell. Atracurium, it can cause a vasodilation and fall in SVR, which can lead to TET spell. And strict avoidance of hypovolemia during the perioperative period is very much essential. For this, we have to give IV maintenance fluid throughout the surgery. Any ongoing blood loss should be replaced immediately with crystalloid boluses. And regarding ventilation, we have to avoid high tidal volume because high tidal volume it causes increase in PVR and it can cause increase right to left shunt. Also, it is better to avoid PEEP. High PEEP it can cause increase in PVR. Usually, tidal volume of around 6 to 8 ml per kg is recommended, and PEEP of 4 is sufficient to prevent any atelectasis causing hypoxia. And respiratory rate, it should be titrated to PaCO2. It is better to maintain PaCO2 in the low normal range, that is 30 to 35 mmHg, because high PaCO2 it can increase pulmonary vascular resistance and it can increase right to left shunt. At the same time, the high PaCO2 it can cause increase in cerebral blood flow, causing ICP rise, which is not good for this patient with cerebral abscess. Regarding maintenance of anesthesia, usually we use sevoflurane with 0.5% effect plus or minus fentanyl boluses. And in classical tetralogy of Fallot, because there is proximal obstruction, so high FiO2, it has no effect on pulmonary blood flow. Whereas in patients, same patient, if he comes to us after BT shunt, or in a patient with single ventricle physiology, if you keep high FiO2 intraoperatively, it can cause pulmonary vasodilation and it can steal the blood from systemic circulation, causing a low blood pressure and leading on to end organ ischemia. So that means pulmonary, we can attain good saturation, but the patient end organs will be suffering ischemia because of low systemic output. And regarding monitoring, any cyanotic child should not be taken inside the OT without pulse oximeter, because in this patient, pulse oximeter SpO2 determines the amount of pulmonary blood flow, and target saturation should be around the baseline, usually around 85%. We should not keep higher saturation, or we should not keep lower saturation. And ECG is used to monitor any paradoxical emboli causing myocardial ischemia, and arrhythmias in the classical tetralogy, it is very rare, but post repair, post ICRA, if this patient come to us, there may be risk of arrhythmia, hence filed ECG is indicated. And regarding end-tidal carbon dioxide, it is since the pulmonary blood flow, it is very low, end-tidal carbon dioxide will also be low in this patient. So we should not titrate ventilation using EtCO2 as a guide, because PaCO2 will be higher in this patient. So the best method to titrate this ventilation is to measure PaCO2 by doing arterial blood gas analysis, for which we need an invasive arterial line. And also we have to monitor acidosis, because acidosis, it increases PVR and it can cause right to left shunt. So an invasive arterial line is recommended in patients with tetralogy coming for non-cardiac surgery. Central venous access, usually it is not required if we have a good peripheral access. However, if there is a poor peripheral access, to infuse phenylephrine or to infuse noradrenaline, we may require central line. Additionally, central line, it can give indication about systemic cardiac output by monitoring central venous oxygen saturation. However, CVP for fluid status is unreliable in this patient, because the patient is having right ventricular hypertrophy. MAC monitor and gas monitor, definitely it is indicated in patient, because we have to maintain optimal depth of anesthesia, because any light pain of anesthesia, it can precipitate TED spell. And temperature monitoring, hypothermia, it increases oxygen consumption, so it is better to keep the child warm, and the temperature probe should be inserted, and the temperature should be maintained around 36.5 to 37 degrees Celsius. And urine monitoring, it is urine output monitoring, it is used for monitoring the systemic circulation adequacy. And it is preferable to extubate such patients on table, because any post-operative ventilation with and ventilator dyssynchrony associated with the post-operative ventilation, it can increase the PVR, and it can precipitate this TED spell, and And post-operative care, these children, they should be nursed in ICU or high dependence unit, because we have to monitor SpO2, and there are high risk for TED spell. And oxygen should be administered in the post-operative period in order to account for any increased oxygen demand because of shivering or because of pain. And maintenance fluid should be continued in post-operative period, and it is better to avoid hypovolemia. And then how to manage a TED spell in this patient? Patient with dynamic RVOT and younger children, they are more prone to develop TED spell when compared to adults or older children. And it can occur anytime. It can occur in the pre-operative room, or it can occur intraoperatively, or it can occur in the post-operative period. And precipitating factors, it includes pain, crying, dehydration, and fever. How to recognize this? There will be increased cyanosis. So the child will be having rapid, deep breathing in the pre-operative period. And if we auscultate, there will be reduced murmur intensity across the RVOTO, right ventricular outflow tract. And how to treat this patient? First, we have to give 100% oxygen, and we have to calm the child. Either we can give chloral hydrate if the child is conscious, or we can give IM morphine 0.1 mg per kg, and we can place the child in knee chest position. Knee chest position, it causes compression of femoral artery, and it can cause increase in SVR, and at the same time it can cause compression of the femoral vein, and it reduces the venous return to the RV, and thus it reduces the right to left shunt. But right to left shunt. IV hydration is also indicated. Usually, IV bolus of fluid should be given in such patients, 5 to 10 ml per kg. And if there is acidosis, we have to give bicarb boluses also. And beta blockers, usually we use esmolol, IV bolus of 100 to 500 mics per kg. And if required, infusion can be started at 100 mics per kg per minute. Vasopressor, we use vasopressors to increase the SVR. Phenylephrine bolus can be given. It can be given at 5 to 25 mics per kg bolus, and maximum dose is around 500 mics. And if the child is not improving, we can start on phenylephrine infusion also. And if all with this conservative measure, if the child is not improving, then we can go for endotracheal intubation. And even with endotracheal intubation, we are not able to bring out improve the saturation, then it is better to indicate emergency surgery. Either emergency BT shunt or emergency ICR can be performed. And my second case is a parturient patient with atrial septal defect with good functional status. She has come to us for elective LSCS, and she is a 26-year-old female with 36 weeks of gestation. She was posted for elective cesarean section, and she was diagnosed to have atrial septal defect at 16 years of age. Her present functional class was NH2 class. Prior to pregnancy, she had no limitation of any functional activity, and she is not on any medication. Her baseline room air SpO2 was 97%, and lab test was normal, and ECG showed features of right axis deviation. Usually in pregnancy, we have left axis deviation because of the mass effect of uterus. The axis of the heart is deviated to left, but in patients with ASD causing huge RA-RV volume overload, we will get right axis deviation. And what are the things we have to see in echo as a non-cardiac anesthetist? So when we are anesthetizing this patient, we have to see for the size of the ASD. If larger the size, larger the shunt, larger the PQS, and RA-RV dilatation and RV function. And we have to look for this pulmonary artery hypertension, because patient with long-standing left to right shunt, they may develop pulmonary artery hypertension if it is unaddressed for a long duration of a period. In our patient, there was only mild TR, and additional anomalies like partial anomalous pulmonary venous connection, which can increase right to left shunt, and it can increase further RA-RV volume overload. And dilated MPS, it is usually due to volume overload, and any other associated congenital anomalies like patent ductus arteriosus or VSD. And MR is an important association in patients with ostium secundum ASD. We have to look for the MR because it may influence our management, and status of the biventricle, whether they are good or not. And regarding the pathophysiology, we know that as the duration of pregnancy progresses or duration of gestation increases, there is increase in plasma volume, increase in heart rate, as well as increase in cardiac output. A maximum increase in cardiac output, it occurs post-delivery or just before delivery. And in patients with unrepaired atrial septal defect, this physiological changes of pregnancy, it can cause further RA-RV volume overload, and it can lead to RV failure in the perioperative period. Also, these patients, they can have a decrease in SVR because of pregnancy hormonal changes. So it may facilitate this right to left shunt in patients who are having a severe PH. And another thing is that in patients with pulmonary artery hypertension, there is a risk of paradoxical emboli, as well as hypercoagulable state of pregnancy. It can also cause emboli and can lead to stroke in these patients. And so our main anesthesia goal in while inducing a patient with ASD with is to first avoid cyanotic shunt. That is, we have to avoid right to left shunt. It occurs only in patients who have severe PH. And second thing, we have to avoid increase the left to right shunt so that RV doesn't fail. And the ideal situation will be to to decrease the SVR minimally, so that there is increased systemic blood flow without aggravating right to left shunt, aggravating the RA volume overload. This is the ideal thing we have. ASD is a left to right shunt, so we may think that there may not be any paradoxical emboli, but we can see from this shunt flow dynamics in patient with ASD, in this chart, increasing positive number, it suggests there is left to right shunt, and negative numbers, it suggests right to left shunt. We can see most phases of cardiac cycle, the shunt is left to right. Only during the mid systole, the shunt changes its direction and it becomes right to left. Hence, it is very much essential to dear the IV line while inducing this patient. And striking a good balance between SVR and PVR, it is a goal of anesthesia in patients with congenital heart disease. We have to know what factors which influences SVR, what anesthesia factors influence SVR. There are factors which decrease the SVR, which includes propofol, volatile anesthetics, neuraxial anesthesia, and blood loss. And the factors which increase SVR, it include ketamine, sympathetic stimulation, and excess of vasopressor. And PVR, it is increased by administration of nitric oxide, and if there is hypoxia, PVR increase, hypercarbia, acidosis, any light pain of anesthesia, and the child starts to buck, or there is bronchospasm or laryngospasm, it can increase the intrathoracic pressure, leading on to increase in PVR. And high tidal volume and PEEP, they also cause increase in PVR. And decrease in PVR is achieved by 100% FiO2, hyperventilating the patient, causing respiratory alkalosis and hypocarbia. So these are the factors which influence SVR and PVR. So we have to maintain optimal ratio of SVR and PVR to improve our perioperative anesthesia care. Either high PVR relative to low SVR causing cyanotic shunt is totally unacceptable, or high SVR when compared to PVR causing RA-RV dilatation and failure of RV, it is also not acceptable. The ideal situation will be we have to decrease the SVR to a minimal degree so that there is more systemic blood flow without increase in RA-RV load. At the same time, there won't be any hypoxic shunt. The choice of anesthesia in my patient was spinal. Other choices will be epidural and GA. Usually it is indicated for other indications. If we are inducing the patient with general anesthesia, IV induction will be slower because of left to right shunt. The drug will be recirculating only within the pulmonary circuit. And if you are using inhaled anesthesia, we may think that there is more pulmonary blood flow and more pulmonary circulation. So there will be quicker achievement of this inhalation anesthesia in the alveoli. But clinically, the studies have shown that inhaled anesthesia has no effect on the speed of induction in patients with ASD. This is because the increased pulmonary blood flow and increased uptake of anesthetics is counteracted by the increased diffusion distance. The anesthetist has to travel from the pulmonary epithelium to the capillary endothelium, which occurs in patients with increased extravascular lung water, like in a patient with ASD. And she's a pregnant patient. Definitely, we have to administer aspiration prophylaxis, and we have to go for rapid sequence induction. And ASD patient does not require any infective endocarditis prophylaxis, but for surgical purpose, we have to administer a single dose of antibiotic. And suppose this patient he comes to us at 40 years of age when she has developed Eisenmenger syndrome, which has led to right to left shunt and causing cyanosis. Then this patient has high perioperative mortality. And what are the predictors in patient are poor functional class, arrhythmia, and syncope. What is our main anesthesia goal? We have to minimize the increase in PVR at any cost. This can be done by keeping the patient hypocarbic, that is PaCO2 of 30 mmHg. And if PVR is still high, we can go for inhaled nitric oxide administration. And preoperatively, the patient can be taking endothelin receptor antagonist or phosphodiesterase inhibitor, so they can be continued. 100% is essential in this patient in order to avoid a right to left shunt. And regional anesthesia is usually preferred, usually spinal or epidural, but I prefer graded epidural in patients coming with parturient coming with Eisenmenger syndrome. And other goal is to prevent fall in SVR by giving phenylephrine boluses. If the patient is undergoing general anesthesia, we have to prevent we have to hyperventilate the patient with low tidal volumes and increased respiratory rate, so that there won't be any increase in intrathoracic pressure. If there is any RV failure occurring perioperatively, we have to go for inodilators like milrinone and or levosimendan with noradrenaline. And so my take-home message is each congenital heart disease has its own specific physiology, which will influence the shunt characteristics and occurrence of pulmonary artery hypertension, and it has an influence on biventricular function. There is increased perioperative risk in these patients, and this increased risk depends upon the congenital heart disease type and severity, and also the complexity of non-cardiac surgery and patient overall functional status. So the key anesthesia consideration will be managing, maintaining hemodynamic stability. We have to maintain we have to strike a good balance between SVR and PVR, and arrhythmia prevention, especially in patients with RA-RV volume modular, like in our patient who has a pregnant patient, and manage cyanosis or pulmonary hypertension. Thank you.
Yeah, thank you, Dr. Chennakesavalu. It's an excellent talk. You covered the very vast topic in 2 cases, and in cyanotic or in acyanotic. So, in a congenital patient coming for non-cardiac surgery, 4 things you should keep in mind always. Number 1 is the type of lesions, whether it is acyanotic or cyanotic, left to right shunt or right to left shunt. Number 2, you should know about the physiology of each lesion. That is very clear. And number 3 is the severity of pulmonary hypertension. And number 4 is associated cardiac lesions and cardiac function. These 4 things you should have the basic about any lesion coming for non-cardiac surgery in congenital. In that, Dr. Chenakesolu elaborated about one in cyanotic, one in non-cyanotic. The one commonly encountered cyanotic lesion is tetralogy of Fallot case coming for any non-cardiac surgery, and particularly for cerebral abscess drainage. In that, he has clearly mentioned that whenever any TOI patient comes, always keep in mind that dehydration should be avoided. Avoid dehydration and hypovolemia. Number 2, avoid de-airing. It is not avoid de-airing. Always do de-airing. Never allow air enters into the circulation. But in terms of induction, you can go according to the procedure, whatever you are planning. But keep in mind that IV induction is preferred over inhalation induction because of in cyanotic patients, IV induction is usually faster and inhalation induction takes very long time. If it is inhalation induction, sevoflurane is the preferred choice in cyanotic patients coming for non-cardiac surgery. And in TOI patients, always prevention of death spell is the most important thing to be followed. In that pain, any pain or anxiety, whatever form, should be prevented, should be treated to prevent the occurrence of death spells. And if it occurs, as you was pointed out about death spell management, you have to follow that. Always oxygenation, knee chest position, then phenylephrine can be used, beta blockers can be used, morphine can be used. So those things are clearly mentioned by him. And number 2 about the acyanotic case, that is atrial septal defect coming for LSES. So this is a common scenario. Whenever there is an atrial septal defect, the severity of pulmonary hypertension is not much. You can proceed with the surgery with a minimal risk, no doubt about it. But keep in mind that the right to left shunt should not occur and left to right shunt should not get exaggerated. So the manipulation of SVR and PVR is the most important thing in acyanotic patient coming for non-cardiac surgery. So this is just an outline. Any discussion we can take up, sir? And from the all the 3 topics,
sir, moderator, sir, there are 2 questions, sir.
Yes, sir.
One,
yes, sir.
This is Dr. Muthukumar. How reliable NT-proBNP in deciding on patients in failure for taking up for non-cardiac surgery?
Yes, sir. Though it is not related to all the 3 topics, I can take up the question, no problem. Dr. Muthukumar Rajagopalan has asked for NT-proBNP reliability or for taking up for non-cardiac surgery. NT-proBNP has clearly proven that 90 to 95% of sensitivity is there with NT-proBNP and occurrence of heart failure. So whenever there is a heart failure, whenever there is an LV dysfunction, particularly severe LV dysfunction in a heart failure patient, the NT-proBNP level significantly will be high. That shows patient is in heart failure. So the sensitivity is very high. So obviously you have to control the heart failure or stabilize the heart failure and then proceed for non-cardiac surgery. That is the safest way. So in heart failure patient or when a suspected heart failure patient, always do this NT-proBNP that is more sensitive than BNP. And if it is significantly high, no doubt you have to stabilize the patient and proceed for surgery. Number two, the question also from Dr. Muthukumar Rajagopalan. Can caudal block be given in TOI patients? Dr. Chennakesavalu? Caudal block in TOI patients.
Yeah, it depends upon the type of surgery. If the patient is coming for a lower abdominal surgery, we can give, provided that INR is within the normal range. We have to check for INR because they have increased hematocrit and polycythemia, which will reduce the plasma volume. Reduction in plasma volume is associated with decreased coagulation factors as well as the platelet count. So they are more prone to develop coagulopathy. But if the coagulation factors is normal, coagulation profile is normal, we can give. And also we have to, while administering caudal, we have to look for any spinal abnormalities like spina bifida, so that we should not inject the drug into the intrathecal space rather than caudal.
Yes, thank you. In a nutshell, whenever there is other contraindications for any regional anesthesia is not there, caudal anesthesia, caudal block can be given in TO patients after induction or after sedation. So in an awake patient, it is not possible because that itself will promote occurrence of death spell. So caudal block can be given in a TO patients after induction. Any other clarification, sir?
If there are no questions, the moderator can go for wind-up discussion as we are reaching 8 o'clock.
Yeah, okay, sir. I can give my closing comments in each. Coming to that three topics, valvular heart disease, cyanotic patients, and regional anesthesia for thoracic surgery. In a nutshell, whenever that valvular heart disease patient coming for non-cardiac surgery, always evaluate the lesion. That is number one. Find out the lesion. It may be a single lesion or combined lesion. So always evaluate the lesion and keep that lesion as a first evaluation point. And number two is there should be an evaluation for presence of other comorbidities and other coexisting cardiac lesions or cardiac function. So the comorbid and cardiac lesions has to be evaluated. That is number two. Number three, risk stratification should be done based on the lesion as well as the risk of surgery. So risk stratification has to be done based on the lesion as well as the risk of surgery. Number four, if there is, as per the European Society of Cardiology and AHA guidelines, it is clearly, as I mentioned earlier, mild and moderate lesions of AS, AR, mild and moderate lesions are MS, MR, all those things, you can proceed for proposed surgery. Only the symptomatic severe MS, severe AS, severe AR, severe MR lesions needs intervention, needs stabilization before proceeding for the non-cardiac surgery. So those patients who require cardiac intervention or valve intervention before the proposed procedure has to be identified and proceeded accordingly. And then last point to be mentioned is these valvular heart disease patients, many of them are anticoagulation therapy. So titrate the anticoagulation therapy accordingly, as mentioned by Dr. Indu very clearly. If there is an oral anticoagulation, stop at least 3 days before. Bring the INR back to less than 1.5 and bridge with low molecular heparin or conventional ultrafractionated heparin. And if you are bridging with the ultra-fractionated heparin, stop 6 hours before. If you are bridging with the low molecular heparin, stop at least 12 hours before. So these things of manipulation of antiplatelets has to be done. Likewise, some of the patients may be with the associated coronary disease, so they may be on antiplatelet therapy. So those things also stopped before procedure. In that, ticagrelor has to be stopped 3 days before, clopidogrel 5 days before, and prasugrel 7 days before. This is the current recommendation. So those things are manipulated and has to be managed accordingly. So these are the points to be kept in mind for valvular heart disease. And for congenital heart disease, as I mentioned earlier, very clear 4 points. Always keep in mind, find out the type of lesion, whether it is cyanotic or acyanotic, left to right shunt or right to left shunt. Number 2, you should be very well versed with the lesion physiology, at least read before taking up the case. And then number 3 is always assess the severity of the pulmonary hypertension. That only going to decide about the right and left shunt aggravation. And number 4 is always keep in mind associated cardiac function, cardiac anomalies, some other lesions, valvular lesions or other shunts. So those 4 things has to be kept in mind before taking up the case. And during the case, always in congenital heart disease, hemodynamic stability is the priority, balance that maintaining SVR and PVR. And number 2, arrhythmia prevention. And number 3 is management of cyanosis and pulmonary hypertension severity. So these things are kept in mind in patients with the cyanotic congenital heart disease patient. And the third topic is regional anesthesia. Siva has very well described about all the blocks very briefly, but each talk will have a separate talk. So yes, completely dealt about the central neuroaxial block like thoracic segmental epidural anesthesia, thoracic epidural anesthesia, and commonly performed now is paravertebral blocks. And myofascial plane blocks also he has described about serratus anterior block, erector spinae block and MTPs. Parasternal blocks also taking up very well. So if you start practicing all those blocks, you can definitely do well. But current evidence, as I said earlier, clearly is there for central neuroaxial blocks. Myofascial blocks are upcoming very in a robust way. So in future, there are a lot of articles will support the myofascial blocks, especially erector spinae block and MTP blocks and serratus anterior blocks. So with this, I once again thank Academic Chairman, Professor Dr. A.L. Meenakshi Sundaram, sir. Thank you very much, sir, for all your support, and thank you for including Meenakshi in you. You're already in having Meenakshi with you, so you're always part of us. And with the goddess Meenakshi support, you will definitely achieve your whatever decided in another 5 days. We are always with you, and best wishes, sir. And thank you, Pthukkottai Bhudhan organizers.
Thank you.
Dr. Munian, Dr. Kannan, Dr. Hema. Excellent work, really appreciable work. And you attracted more than 800 delegates. Every meeting is really phenomenal. Thank you very much. Have a good day. Thank you, sir.
Thank you, moderator and the team. Now I request our treasurer
Thank you, sir.
to propose vote of thanks.
Good evening, everyone. I thank you all for your presence in today's episode on cardiac patients for non-cardiac surgery. Our sincere gratitude to Academic Chairman Dr. A.L. sir for his guidance. Thank you, Department of Anesthesiology, Meenakshi Hospitals for the presentation by the eminent speakers. Dr. Siva Prasath, Resident Meenakshi Mission Hospital, Madurai. Dr. Indu Kundandaiyan, Consultant Meenakshi Hospital, Thanjavur. Dr. Chennakesavalu, Consultant Meenakshi Hospital, Thanjavur. Thank you, moderator sir, Dr. S. Kumar, Senior Consultant and Head Cardiac Anesthesiology and Critical Care, Meenakshi Hospital and Research Center, Madurai. Thank you, sir, for enlightening our audience and guiding us today. Thank you, sir. Thank you, Clarinet, for your continuous support. I thank all the participants, colleagues, postgraduates, and consultants for your encouragement. Kindly vote for our academic chairman, Dr. A.L.M. sir, for the post of president-elect in the upcoming election, ISA 2025. Thank you all. Good evening.
Thank you. And now I request
Thank you, sir.
Clarinet to propose the concluding remarks and close the session.
Yes, sir. Thank you so much, everyone, for joining this session. It was a very
very wonderful session. So, and LearnIt is really glad to have all these brilliant people together. So, with all your permission, I'm closing the session for today. Thank you so much,
Thank you.
everyone.
Thank you, sir. Thank you.
Thank you, sir.
Thank
Thank you,
you.
sir.
Thank you,
Thank
sir.
you.
Thank you,
Thank you.
sir.